Dory.
Hi, everyone. How are you guys?
Good evening.
Thanks for joining, Ingela. We're so glad to have you.
Oh, it's an honor to be invited.
Excited. Hopefully we get a good turnout. It's, after the holidays, so we'll see how many people show up, but
Yeah.
it'll be recorded regardless and put on the ACC website.
Uh-oh. More pressure than on me, right?
No, it's okay. It'll be good. Sometimes it's a small group of fellows and it's very intimate and people ask questions and it's fun. So it'll be good.
And there's fellows from all the institutions in California, or how does that work?
Yeah, so our FIT committee has fellows from 7 different institutions, and the email goes out to all of everyone that's registered with California ACC. So it's all fellows in California. Get the email.
It also, if I'm not mistaken, has also been expanded to all of California ACC, including mid-level providers, attending physicians, anybody within the state. Once Natalie and I kicked off the first one, we thought that it would be really nice to open it up. It's topic review, it's other really relevant discussion, and potentially provides an opportunity for people at other centers to see some of the wonderful things that are happening. And hopefully we continue the trend of having increased attendance at every meeting, but we'll see.
Wow.
So thank you so much for taking the time. And just like Natalie said, it's hopefully a nice intimate thing. You're the expert, so you can opine on whatever you'd like, and I'm sure we'll all learn things one way or another.
My pleasure, my pleasure.
And Nikhil is an interventional fellow at Loma Linda, and he's my Southern California counterpart.
I see.
Mm-hmm.
Is a counterpart is a term that Natalie uses with a great deal of flexibility, because I've always told her she does a lion's share of some of the stuff for our committee, and we would be nowhere without her leadership.
It's a team effort, Nikhil.
Yeah, there's no I in team, but there's I in win, and you win. So there you go. How about that one?
Oh my God.
That was pretty good. I came up with that one on the fly. Sorry.
Pretty good.
Too much radiation, right?
Oh my gosh. Do you want to see if you can share your slides if everything looks okay?
Sure. Let's see here. Host disabled participant screening sharing. Okay.
Uh-oh. Okay. You're listed as a co-host. You both are. So
Okay,
hopefully it should.
Maybe we can.
There it goes. Perfect.
Oh, perfect.
This is, Whitney on behalf of Leanna. She was not able to join us. Hi, guys.
Hi, Whitney.
Oh, hey, Whitney. How are you?
Hi. Good. I'm making you all co-hosts, and then I do have instructions to make one of you the host, as I do have to leave the meeting, but then you all can go ahead. Who wants that privilege, I guess?
Natalie.
Sure.
Natalie, it's just if you end the meeting, it will end for all, and then it's already being recorded. We'll edit all this out, obviously, before we post it in. But
Cool.
Got it. Okay.
That's
If
like-
Nikhil, is your internet really strong?
It should be. I'm sitting right next to my router. If you want to make me host, that's fine.
I think you should make Nikhil host, only because my internet sometimes can go out, and then I would hate for the meeting to end if that happens.
Yeah.
No,
And
I
then
feel
now
like I
that
should go run a
everybody's-
cable.
Yeah. The only thing too, if anybody else is sharing screen, just co-host them, Nikhil, and then it'll be good. Okay, sorry.
Okay,
Sure.
awesome.
Yeah, I think.
And the recording will be like automatic, Whitney? We
Yeah,
don't have
it's
to do
already set.
anything? Okay.
Yep, it is already set when the meeting starts, and our web team will edit out this part of it before we post it on the website.
Okay. Awesome.
Fantastic.
Enjoy, you guys.
Yeah. Thank you.
Thanks, Whitney.
Yeah,
Thank you.
no problem.
Let's see what kind of shenanigans I can do. I'm on my iPad. I normally am on a computer or something else, but let's see.
So Nikhil, Dr. Hilliard's not joining, so I guess we can do the intro.
Yeah. Yeah.
If you want to start, and then I can introduce Ingela afterwards.
Sure.
Okay.
Whatever you see is best. This is our third one, right?
Third one. Yeah, we had Dr.
Lipids,
Wilkinson from UCSD, and
Venetia.
Yeah,
Okay.
it's our third one.
Okay.
Yep. I'm gonna send a blast to all the fellows again.
I sent one out to all of Loma Linda.
Mhm.
Nobody responded to me, so who knows?
Rasheen sent out an email to all of Stanford, so hopefully we get a good turnout.
Cool. So how's the sleep coming?
Oh, for me? Oh, still waking up every 2 hours. Ingela,
Okay.
I had a baby 2 weeks ago.
Oh, congratulations.
Thank you. So I've been waking up every 2 hours overnight.
It's
been
worse
rough.
than intro, isn't it?
Yeah, but see, you could look at it two ways, right? You're waking up every 2 hours to feed and nurture this wonderful thing, or you're waking up every 2 hours to respond to frivolous pages.
That's true. That
Yeah.
is very true. Although
Right?
I think the baby is worse than first year cardiology call. I think it is.
Yeah.
It's just because you're too far removed from all the calls, so it seems painful. But if you're in the thick of it, you're like, oh, this isn't so bad.
Maybe. I
Or
don't
I'm
know.
just, or I just have some sort of, delusion of grandeur.
I think because you're in the midst of interventional fellowship, you're having a rough time.
Yeah.
But third year over here is pretty nice. Aside
Yeah.
from working on my research projects, no one expects anything from me. So it's pretty nice.
Wow, that's awesome.
We got one of our FIT committee members just joined. So hopefully we get more.
Yeah.
Have your other meetings been at this time, or are we unusually late, or?
Yeah, we usually start earlier than this one.
About
So this one's a
5:30,
little
but
bit
not by
later.
much.
Yeah.
Okay.
So hopefully we'll see.
Yeah.
The first one we had about 20 to 25 people join.
Okay.
So we'll see. Hopefully we get a few more. I'm just texting all the fellows right now. So Nikhil, you want to send an email out to your people too?
Yep, I'll ping them again.
Okay. Hi, Andrew. How are you doing?
Hey, Natalie, I'm good. How are you? Excited for
Good.
Saturday?
Yes, me too. Awesome. Thanks for joining.
Of course. Thank you for hosting as always.
Of course. And I see Pamela joined. Pamela is, I forget what state you're from, but you got the message through the national ACC WhatsApp. I don't know if you're in a place where you can talk.
Yeah, hi Natalie. Well, I'm actually an international ACC chapter fellow. I am from Dominican Republic.
Oh, wow.
Oh, wow,
Yeah.
wonderful.
Well, it's really nice to be here with you tonight.
Thank you for joining. Wow,
Yeah,
I'm
it's a really
impressed.
interesting topic.
Yeah, that's why we wanted to do this one. If you have any co-fellows or anyone else that you want to send a last minute, message to, please do that so we get.
Yeah, I've already forwarded to a lot of people, so.
Awesome. Perfect.
Yeah,
Thank
thank
you. Hey, Tintin. Tintin is our most regular attendee.
I know.
Hey guys.
I know.
How
Hey,
you doing?
Tintin, how are you?
I'm good. How are you guys doing?
Good. And hopefully you also sent a blast to all your co-fellows too.
Oh, about yeah, I told them.
Okay, awesome. We'll give it like 5 more
Just
minutes.
a couple minutes, yeah.
Yeah. like we have more people joining. If people don't mind, either putting in the chat or changing their name, so, let us know what institution you're from, or if you're not from California, what state you're from, that would be awesome.
Mhm.
Got a lot of Loma Linda representation, Nikhil. Good job.
So, no, they are all to be commended. They put up with me, so I appreciate their flexibility.
You do a good job harassing them to join.
I was hoping that it would be a nicer term than harassing, but
Okay, hey Ramsey. We're just asking all the people who are joining now, if you don't mind just putting it either in your name or in the chat, what institution you're from or what state you're from if you're not from California. That would be awesome. And we'll get started in just maybe like 2 or 3 minutes.
Yeah, sounds great.
Okay, Nikhil, do you want to start? And then if more people trickle in, that would be
Yeah, sounds
fine. So that way we
sounds
can
great,
get
man.
out on time too. And
Yeah.
it's recorded, so it'll be fine if people join later.
Sure. No, I think this is perfect.
Okay.
Well, good evening and happy Thursday to everybody on the call. It's my distinct pleasure with Natalie to bring to you the third installment of our Connecting California initiative in the California ACC Fellows and Training Lecture Series. This is the brainchild of Natalie, who is the wonderful ACC catalyst for Northern California, and I've been very, very grateful to be able to work alongside her throughout this academic year thus far. We have a very exciting program for you this evening. I'll let Natalie, of course, introduce our wonderful speaker. I think there's some really, really wonderful learning to be had and some hopefully wonderful tips that we can all take back to our individual practices, whether it's fellows, early career attendings, or even late career attendings, and potentially disseminate some of this wonderful information that'll help us take better care of patients that we interact with on a day-to-day basis. So without further ado, I'll turn it over to Natalie.
Thanks, Nikhil. And Nikhil is way too modest. We planned this whole lecture series essentially to highlight unique faculty members who have clinics that might not be represented at every institution in California. And so our FIT committee members brought about topics that they found were lacking in their programs, and we sought out faculty members who were experts in those topics. And so we have representation from all across California, and we even have an attendee from the Dominican Republic today. So it's pretty exciting. And then our lectures will all be recorded and placed on the ACC FIT website, and we'll put a link to that in our chat afterwards. So our speaker today is Dr. Ingela Schnitger. She's a professor of medicine at Stanford. And she's an amazing attending that 2 of us or 3 of us on this call have worked with extensively. And so we're really glad that she's here today and accepted our invitation. So she received her medical education at Karolinska Institute in Sweden, after which she completed internship and residency both in Sweden as well as University of Connecticut Health Center. She went on to complete her cardiology training at Stanford University, where she's been an integral leader in the space of cardiovascular echocardiography for many years. She's served as the Chief of Academic Affairs and Associate Chief of the Division of Cardiovascular Medicine at Stanford from 1999 to 2019, and then served as the Medical Director of the Stanford Echo Lab from 1997 to 2022. She's been extremely pivotal in shaping the Stanford Echo Lab into the very robust department it is today. She's taught countless fellows and sonographers in the art of echo, and she's been the recipient of clinical teaching awards for her dedication and her excellence. She's also a world expert in myocardial bridge and has published extensively on this topic. She's also, very interestingly, the first cardiologist at Stanford who implanted a cardiac pacemaker back in a time when it was only implanted by cardiac surgeons. So very fun and interesting fact. She's a pioneer in the field of cardiology, and California ACC is so honored to have her present today about the topic of myocardial bridge as part of our Connecting California lecture series for fellows in training. So thank you so much, Dr. Schnittger, for joining us, and you can take it away.
Thank you very much for that very nice introduction. I'm honored to be here today and teach you and show you what I have learned about myocardial bridges in the last 10 to 12 years. So without further introduction, let's get started. Can you see my slide?
Yes.
Yep. Okay. So I will tell you about the Stanford Myocardial Bridge program, which is, I believe, the only such program in the country. What is a myocardial bridge? Well, just very briefly, of course, the coronary arteries are supposed to ride on the surface of the heart on a nice bed of fat. If the coronary artery fails to migrate to the surface during the fetal development, you end up with a segment of the artery that is buried under a band of muscle fibers. It turns out that you have muscle fibers going from the left heart to the right heart to bridge the interventricular groove all the way from the apex to the base. And the myocardial bridges are typically just below the first or second diagonal branch. Now, why do we care? Why do we care about myocardial bridges? Well, the prevalence is actually surprisingly high. So 20 to 25% of all people walking the streets of Palo Alto or anywhere where you are in the general population do have a myocardial bridge. And although many patients are asymptomatic, some are not. Well, what are the symptoms then? Well, if they have symptoms, they have angina without any obstructive coronary disease. They can have acute coronary syndrome, including MIs. Ventricular arrhythmias are common, and even sudden cardiac death is described, and we've seen it here. So this is kind of a sort of an odd condition. Why did I get interested in MBs? Well, years ago, I was asked to review a medical record for a legal case for a primary care physician who was the defendant in the malpractice case. And the case was about a 38-year-old male, very fit, very athletic, who had a history of exercise-induced chest pain. He had no risk factors for coronary disease. His treadmill test that was ordered by the PCP was normal. But then one day, he had an acute MI while running on a treadmill in a gym, had a VF arrest, and died because of brain death. The autopsy showed a myocardial bridge with a plaque proximal to bridge, acute plaque rupture, acute total LAD occlusion, VF arrest. Well, not surprisingly, I had never heard of a myocardial bridge. I did not know what that was. And the plaintiff's lawyer, he knew more about bridges than I did. It was very embarrassing. Well, so then a few months later, I'm sitting at my desk in the echo lab, and I read a stress echo on a young 35-year-old male who was referred for chest pain. And I was perplexed by the abnormal septal motion, and I asked myself, could this be an MB? Because it was very unlikely that this young man had coronary disease with no stated risk factors. Well, it so happened that he had a follow-up coronary angiogram, which showed an LAD bridge. Well, this was the birth of the Stanford MB program. Well, so our program is really a multidisciplinary program. Of course, the non-invasive imaging lab is in a way the center where we would do the stress test. I'm working very closely with interventional cardiology, specifically Dr. Jennifer Trammell, and I have one and only cardiac surgeon, Dr. Jack Boyd. We have a fantastic intravascular ultrasound lab at Stanford ran by Yasu Honda. I work with a handful of CT radiologists who have become familiar with this condition and learn how to accurately assess bridges on CT. We have a clinical and a research coordinator. I work with the regional anesthesia group, a group that provide nerve blocks for our patients if they go on to surgery. A few facts about myocardial bridges. As I mentioned, they're present in up to 25% of the general population by autopsy. By angiogram only, you can see it may be 5% of angiograms. So this is something for Nikhil to take to heart. 95% of bridges are in the LAD. It's interesting that bridges occur in about 60% of patients that end up going to the cath lab because of chest pain and who turns out to have no obstructive coronary disease. And so in those patients, you have to look at, well, what could have caused the angina? Well, 60% of that cohort will end up having a myocardial bridge. Myocardial bridges are congenital anomalies, but symptoms typically do not develop before the third decade. A few more facts. So patients with myocardial bridges that are significant will have exertional angina. And I want you to also know that angina can occur at rest with emotional stress, likely due to frequently superimposed endothelial dysfunction inside the MB, resulting in endothelial-dependent vasospasm. This is important because these patients will present to you with chest pain that is effort-related and then chest pain at rest. And as cardiologists, we would often say, your pain is not typical for angina or for coronary disease. So, honey, just take it easy. This is all, anxiety. But you should know that 85% of people with significant bridges do have endothelial vasospasm. All right, patients also often have frequent PVCs. VT syncope can be a presenting symptom. When we study these patients on the treadmill, 45% have PVCs occurring during stress, and 5% have non-sustained VT. And these numbers are significantly higher than for people that on the treadmill perform on the treadmill and have no coronary disease and no other significant myocardial disease. So for us as cardiologists, it's important to know that although MBs are frequent, it can be an incidental finding. But in some people, a subgroup, they do have angina, They can have an MI, VT, and even sudden cardiac death. So the challenge is for us to distinguish an incidental asymptomatic MB from a hemodynamically significant one. And I hope in the next few slides to take you through that journey. So if you have a patient with chest pain, concerning for angina, you're pretty sure it's not musculoskeletal. At Stanford, we often would do then an exercise echocardiogram. And if we see something that I have labeled focal septal buckling with apical sparing, that is suggestive of MB, and I will shortly show you what this pattern looks like. If the segmental wall motion abnormality is suggestive of obstructive coronary disease, i.e. it follows a known coronary territory, of course you have to go down that road. If there's no suggestion of either coronary disease or MB, you may have to pursue other diagnostic possibilities. So here's the 4-chamber view, echo, septum, apex, and lateral wall at rest. Now at stress, you see this perplexing sort of odd septal buckling in the middle of the septum. And please observe the fact that the apex is preserved. So this is kind of, you know, sort of a unusual pattern. This is not left bundle. This is not anything else that I've ever seen. So I saw this pattern in this young man in the echo lab, and I'm like, wow, what is this? Okay. Now, in order to see that septal buckling, you do need to record several complete cardiac cycles. I don't know any lab out there that does that because most labs will only record half of a cycle and end at basically the peak of the T wave. So if you do record multiple cycles and then go frame by frame, you will see that here at the peak of the T wave, the septum still looks fine. In the next frame, still looks fine. When you start to go to the downslope of the T wave, you start to see a slight buckling, then more buckling, and then it starts to straighten out. And here, basically during the isovolume relaxation time, early diastole, you start to see the septum straighten out. So if you do frame by frame, you can see that, but you need to have several cycles also because there can be quite a bit of translation because of the lung moving. So you need to record it this way in order to see this pattern. We have looked at the accuracy of this pattern in the retrospective as well as in the prospective cohort. And what we found was that if we took patients that had the MB pattern on stress echo and compare them to coronary CT, what was the accuracy? Well, of 158 patients that had the MB pattern, 107 had a bridge on CT scan. So the sensitivity was good. The specificity was not quite as stellar. Now, these were all comers. These were people that were referred to the echo lab for a stress test. Some had chest pain. Some were just having like a family history of heart disease, or they were it was a routine preoperative workup because they were going to be a kidney donor. So they were all comers. Now, when we looked at the prospective cohort, we looked at patients that actually came to the Stanford ED with chest pain. And we had 37 patients that had the MB pattern on stress echo. 31 of those had a bridge on CT. So the sensitivity is still good, and the specificity now a bit better when you have a patient that has a reason for study being angina. There's still obviously some false positive, and we can have false negative. But if a patient comes with the recent chest pain consistent with angina, these are the kinds of numbers that you can expect. Now, we have established what we call a myocardial bridge clinic. So this is a dedicated clinic where we see patients with chest pain or shortness of breath with exertion that have either had a suspected bridge by stress echo or confirmed by already having had a CT or perhaps an invasive angiogram. We have an RN and a program scheduling coordinator. We collaborate, as I mentioned before, with other departments, CT readers, interventional cardiology, IVUS lab, and a cardiac surgeon. So if you have a stress echo suggestive of MB and it's an incidental finding, you don't need to do any further workup. The patient has no symptoms. The stress test was not done because of chest pain or dyspnea on exertion. However, if they have chest pain suggestive of angina, you may consider starting them on a beta blocker or calcium channel blocker, especially if their heart rate is not that low and the blood pressure is not that low and they can tolerate these kinds of medications. Now, if you feel that you need further confirmation or not, or the patient may want to have further confirmation or not, we go ahead and do a coronary CT. If bridge is confirmed, we get a little bit more aggressive about treatment. We consider statin if the LDL is elevated and a baby aspirin, and I'll come back to why we need to look at that. If MB is not confirmed and obstructive coronary disease is ruled out, then of course you go down another road. So to confirm or not the presence of a bridge, the next step is often a coronary CT scan. And there was a paper published by Dr. Kim et al. From Korea about 13 or so years ago, which was very useful for us because they classified the bridges in the following way. So this is a short axis of the left ventricle and the right ventricle. Here is the interventricular groove. Here's the LAD. The LAD is sitting nice and free from the myocardium. Black is fat, so this is fat. This is entirely normal. The next stage is a partial encasement, i.e. the artery is touching the myocardium. You cannot see a roof, so it's just partially surrounded by muscle. The next step is full encasement, but you cannot yet measure a roof because the resolution on CT is 0.7 millimeters. So there is a roof here, but it's thinner than 0.7. And this is full encasement where you can actually measure the myocardial thickness. And these are pictures of a real CT scan depicting these 4 different situations. Now, so we use that classification scheme when we took patients that had a myocardial bridge by CT that went on to invasive studies where we had intravascular ultrasound and also stressed the bridge and measuring fractional flow reserve. So what we did was that we used the Korean classification scheme from the CT, and we coded partial encasement as grade 1, i.e. it's a superficial bridge. Full encasement without measurable overlying myocardium would be a grade 2, and full encasement we coded as grade 3. So then we simply created an index where we took the grade 1, 2, or 3 times the length, and that gave us a muscle mass index. And then we compare that muscle mass index from the CT with the invasive studies. And if that number was greater than 31, we had a sensitivity of 74 and specificity of 62 to predict a hemodynamically significant bridge when compared to diastolic fractional flow reserve. Now, you can say those are not very stellar numbers, but so if I get an index of 31, it's often hemodynamically significant, but sometimes it's not. However, if I get double that, if I have an index of 62, I haven't seen a single patient that didn't have a hemodynamically significant bridge. So this is a very useful tool for me and my colleagues as far as not only document the presence of bridge, but also get an idea of, is this a significant, a possible significant bridge, or is this a totally insignificant finding? In the patient's chest pain, you may have to find another cause of. So if MB is confirmed, you really should consider a beta blocker. My favorite one is nebivolol, because it also has a positive nitric oxide effect, which is great for your endothelial lining. And since many of them have endothelial dysfunction, this can work both if they have exercise-induced pain and also resting pain. My second choice is metoprolol, but metoprolol does not have the positive NO effect. If they cannot tolerate the a beta blocker, you could consider a calcium channel blocker. Also, if they have a lot of spasm, diltiazem, verapamil, and amlodipine, we have used them all. Probably my favorite there is still diltiazem, but I still go here first. I do really pay attention to their lipid panel, and I'll come to that in a bit. And if their LDL is elevated, you need to take it down and a baby aspirin. Most people that I see will respond to medical therapy. You may have to titrate up to tolerance, and they often, are improved enough that the quality of life is tolerable, and they can manage their symptoms. Now, about 5 to 10% of patients will fail medical therapy. You push your drugs as hard as you can, and they either don't tolerate it or they still have symptoms. And then I would consider an invasive coronary angiogram with IVUS. And we do then test the hemodynamic compromise of the MB by looking at the diastolic FFR. If they do have an ischemic MB, i.e. a DFFR less than 0.76, we can either consider continuing medical therapy if the patient would not consider surgery, but if they are here, they are potentially surgical candidate for unroofing of their bridge. If the MB turns out not to be ischemic, you have to look at presence of microvascular dysfunction, endothelial dysfunction, or yet another cause of chest pain. When we do the invasive angiogram, we measure the coronary pressure in the bridge at rest and under debutament stress to mimic what happens with exercise. We calculate the diastolic fractional flow reserve, and I'll show you how we do that. We also evaluate vascular function. We test endothelial function with acetylcholine and microvascular function. We do intravascular ultrasound on all these patients, and we measure a number of parameters of MB. So these are pressure measurements at rest, proximal to bridge, in bridge, distal. The yellow line here is the coronary pressure, and the red line is the aortic pressure. So you can see at rest inside the bridge, they're still pretty much exactly the same. Now, if you do a Doppler recording, you have what is called the fingertip sign. So early in diastole, the coronary flow velocity is a little bit increased, but it quickly becomes normal. So this is what we see at rest. Now, when we give dobutamine up to 85% of predicted for age, this is what happens. Proximal to bridge, again, superimposable pressure curves. Inside the bridge with stress, the diastolic pressure is dumped compared to the aortic pressure. And because you get, in systole, you get a constriction of the arterial segment from the band. So you get an overshoot. And so if you were to just average for the whole cycle, you are not going to get a significant difference between aorta and coronary pressure, because the systolic overshoot will normalize, or in part normalize, the diastolic dump. And since coronary pressure is predominantly during diastole, this is the important time period. So we just have to look at the average difference between aortic and coronary pressure in diastole, and that's how we calculate the diastolic FFR, which is different from what you do in a fixed coronary lesion, where you actually just look at the mean pressures. Distally, there's still some small difference, but not significant. The Doppler velocities are sky high inside the bridge during the stress. Now, interesting, and this is it's important because this has to do with plaque, okay? When we have the pressure and Doppler wire in the coronary artery and pull back, this is what we see inside the bridge. This diastolic FFR was 0.61, very significant. The Doppler velocity is high in diastole inside the bridge. And then when we pull back and come out of the bridge and we go proximally, you see this phenomenon. You see systolic reversal. Because, of course, when the band clamps down on the artery, you get backflush, okay? So you get systolic reversal in the blood flow above bridge. Why is that interesting? Well, here's the reason. The shear stress is very low, and we have measured this, we published this. So the shear stress goes down proximal to bridge because of the systolic reversal. So people develop plaque upstream from the bridge, statistically speaking, 20 millimeter upstream from the entrance to the bridge. And the fascinating thing is that the lumen of the coronary artery, this is an ultrasound, intravascular ultrasound, the lumen is preserved. So you don't see this on an invasive angiogram. You don't see it on CT. You have to do IVUS to see it, because the vessel undergoes eccentric remodeling. All this is plaque. So this is a significant plaque burden if you look at the total vessel size. And it turns out that these plaques are more vulnerable to plaque rupture than a plaque in the same position in a person who doesn't have a bridge below. And this has been shown by a Japanese group. And this is why you should have these patients on a baby aspirin, and this is why you need to hunt down other potential coronary artery disease risk factors, such as LDL cholesterol. And nobody knew this until we started to do ultrasound, and we're not the first one to show that this has also been shown by a German group. But anytime I hear or see a young person have a myocardial infarction and no risk factors that are obvious, think bridge. All right, so if they fail medical therapy, they have a proven ischemic bridge, we can consider unroofing surgery, and we can do mini thoracotomy or sternotomy on pump or off pump, and we have published on this. We do about half mini and half sternotomy, and it's totally dictated by the technical side of the bridge. How long is it? How deep it is? What is the location? Is the artery going into the RV, which it can do? You want to be on pump, you want to be on sternotomy. So this is a surgeon's decision what approach is taken. Of course, the patient will want to favor a mini thoracotomy, and we do too, but we don't want to compromise the fact that we need to be safe and we need to unroof the entire bridge. So when we looked at our first 50 patients that underwent unroofing, we did what we call a Seattle angina questionnaire, and that questionnaire has 5 different groups of questions: physical limitation, angina stability, frequency, treatment satisfaction, and quality of life. And the blue is pre-op and the red is post-op. So they all statistically improved at 6 months mark. And the most significant is the quality of life. They would statistically state that on the average, the quality of life was 25% of what they wanted it to be. And it went to 79% at 6 months. Some go to 100%, some goes to less than 78%. It is to some degree depends on how much endothelial dysfunction they have, and they need to have requirement for some treatment of that moving forward. But overall, this surgery is considered for symptom reduction. We cannot guarantee they're going to live longer. We cannot guarantee that they're never going to have a heart attack. So it's for symptom relief and improvement in quality of life. So with that, I am going to present to you a case. So this is a 52-year-old PE teacher with more than 10-year history of chest pain, shortness of breath, racing heartbeats. He has had increasing symptoms the last 5 years. He can't run anymore. He can't work in the yard. He feels fatigued and exhausted. And it's a challenge for him to keep his job as a PE teacher. And his own statement was, "My quality of life is terrible." He has a normal lipid panel. He's a non-smoker, normal blood pressure. He's been on metoprolol at a decent dose. He's previously failed verapamil, atenolol, and nitrates. He's had multiple ED admissions locally in the one of the California valleys. This is very typical. Multiple admissions to ED for chest pain, an evaluation for ACS, and sometimes they may have a little trope leak and sometimes not. An outside coronary angiogram showed no significant coronary disease, and he was told at one point he had a myocardial bridge, but it was just sort of sidelined, and he was told that that was not a problem. Well, eventually he was referred to Stanford for further evaluation because one of his caregivers or cardiologists thought that maybe that could be an issue. Came to Stanford, had a stress echo, 12 meds, a good heart rate, no ST segment depression, but he did have chest pain and he had occasional PVCs. He had focal septal buckling with apical sparing, suggestive of bridge. He had a CT scan. Sorry, this goes very quickly. I'm going to try to take it slower for you. Okay, so here's the aorta, and we're going to see, here's the left main, here's the LAD, this is going to be the circ. And as we go forward here, you're going to see there is the takeoff of the first diagonal. And as we go forward now, you can see that the LAD is surrounded by muscle. Muscle is gray, fat is black. Here's the diagonal. So the LAD is supposed to be out here on the same level as the diagonal, but it's embedded in muscle, still embedded in muscle. Now it starts to come pretty close to the RV cavity. And that's something that the surgeon will, if the patient is going to surgery, will have to really look out for. And at some point here, you're going to see that LAD will pop up and go out in the epicardial fat. So here it's out. So that's how we are looking at the bridges from a short axis view. Then we, in the long axis plane of the LAD, we measure the bridge, which is going to be from here to here. And we measured that, it was 45 millimeters. And here is a still frame of just what I showed you, where the artery is completely embedded. So this would be graded as a grade 3. And here it's popped out. So the radiologist read this as no atherosclerotic plaque visualized, length 45, grade 3. So he got a muscle mass index of 135. We also pay attention to how many septal branches are in the segment. So this is a very significant number, very high probability of being hemodynamically important. He had an angiogram, of course, and here you could see the bridge by angiogram, but it's not very impressive. And you kind of have to squint and look carefully. And Nikhil probably has seen bridges that look like this, or sometimes it's even hard to see it because you have branches that cross all over and a lot of motion of the heart. But when you see it, this is a still frame, you can see a certain degree of milking of the segment as systole compresses the vessel. So his invasive study showed a diastolic FFR of 0.61, very significant. And this is the intravascular ultrasound. And I'll take you through this journey because it's kind of fascinating. So we are now sitting with our IVUS catheter. We're down here, okay? And then we're going to pull it back and we're going to see the bridge as we come back, okay? So this is the artifact of the catheter, and here is the lumen of the vessel, okay? Now I'm going to play this, and that looks fine, and we're looking for bridge. We're looking, there is the bridge, okay? That echolucent halo, that is the muscle band. And it gets a little bigger and a little bit bigger, and you can see how it's contracting, and we're going to keep going here. And at some point, it gets very big. So there is where we go into the grade 3. Now, look at the compression of the vessel. It's impressive. This is at rest. The vessel is inverted. So there's a lot of pressure here. The vessel is completely inverted, okay? So the compression here was high, 45%. We continue to pull back until bridge disappears, and that's how we measure length. And then as we come even further up the tree, you're going to start to see some plaque. We have to go up to about 4,500. And at this point, we're not there yet. We're not there. Now you start to see a little bit of a rim of plaque, okay? And so we look for the max plaque burden and the position of that. Here you see again plaque, okay? So that's the IVUS run. And if the patient is heading for the operating room, we do something that we call an IVUS map. This is what the surgeon wants because he needs to know his landmarks. So we mark out the location of the bridge where the IVUS catheters start. We look at how many septal branches are jailed in the tunneled segment. We look at the correlation to the diagonals and the circ. And our IVUS lab will measure out the length and the location. And that's very important for the surgeon to know to identify the exact length and position. And then we look at the compression, which you already saw was significant, 45%. More than 10% is abnormal, okay? And then we measure the max plaque burden, which was modest in him, but as predicted, 22 millimeter above the entrance to the bridge, that's where the max plaque burden occurs. Here is the width, the depth of the bridge. We call it the halo. And we look at minimum luminal area, which was in the bridge was 2.6. And that's important for other reasons. So then we get these measurements. And in this case, the patient underwent unroofing surgery, having failed medical therapy, and invasive studies showing a hemodynamically important bridge. This is the surgical shot. He's on pump sternotomy, and here's the LAD. But you know, sometimes it's not exactly easy to find out where does it start. And sometimes the roof is thinner, and did I actually unroof that correctly? So what the surgeon does is that he actually takes out a measurement stick, and he will measure the unroofed segment and make sure it correlates to the IVUS map. And that's how you ensure that you have made the complete unroofing of the bridge. In this case, the patient did very well. 4 months later, he was fully recovered. He was back to coaching PE after he had completed some cardiac rehab. So this is my last slide. I've just put together a selected number of references from our bridge group. If you're interested, this could be the start of learning more if you so are inclined. And that's the end of my story.
That was fantastic. Thank you so much, Dr. Schnitger. That was a whirlwind tour of myocardial bridge. So thank you. We have some really interesting questions in the chat. So I can start off with the first one. If anyone wants to unmute and ask the question themselves, feel free. So I don't know if Ramsey's still there, but I can ask your question for you if you're not.
Hey, Natalie.
Go for it.
Yeah, Ingela, great talk. Really, really amazing. I was just curious about Revivol, and a lot of these people are athletes who might have low resting heart rates. I'm not too familiar with it. Like, what dose do you start with? How often do you titrate? When should you think about treatment failure when you do use that?
Yes, excellent question. You obviously have to consider the resting heart rate and blood pressure. And if they're running a resting heart rate of 60 or 58 or something along those lines, I start very, very low. The Bivol, the lowest pill size is 2.5 milligram, and I would start even half over 2.5, i.e. 1.25, because you also don't want to, start out with a big dose and then they're going to quit, right? But it turns out that you can usually get a small dose on board, and small dose enough that they still get some improvement. But that may be the toughest group to treat if they really are. I mean, I have had marathon runners, and I get nervous when the marathon runner is running marathon and get chest pain for many reasons. And they could be the toughest ones to treat. Now, you could try amlodipine as a calcium channel blocker, which will only affect blood pressure but not heart rate. But yes, I would start typically, if the heart rate is very low, I'll start 1.25. If the heart rate is 65, 70, I can easily get on board 2.5 milligram. Or I split it 1.25 in the morning and 1.25 in the evening.
Awesome, thank you. So our next question comes from Sohab. Sorry if I mispronounced your name. If you want to unmute yourself and ask your question, go for it.
Yeah, hi. Thank you for great talk. I was wondering regarding FFR, if like the non-invasive CT FFR, has that been studied in myocardial bridge?
Yes, we have studied that, and it is not useful. It's not accurate to use the FFR calculation that we do with CT. It's good for fixed coronary disease, but for bridges, so one problem is that the bridges may not be hemodynamically important unless you drive up the heart rate, right? So we need a heart rate of 85% of predicted, and when you do a CT scan, you do the opposite, you slow down the heart rate. So it's not possible to study them with CT with the conditions that are needed to see the dynamic impact on the bridge.
Okay, thank you.
Unfortunately, because it would be very handy, but I think using our muscle mass index, it's not an FFR, but as we have correlated it with invasive diastolic FFR, I feel that it's very valuable in clinical practice, because I think that you can fairly quickly sort out who probably have a significant hemodynamic MB versus those that don't. I mean, if you get an MB that is 10 millimeter long and grade 1, and you have an MMI of 10, they're not going to have a significant MB when you test them in the cath lab.
Awesome. That makes sense. Okay, our next question. We have 2 questions from Nicholas, if you're still on and you want to ask your questions.
Sure. Thank you, Dr. Schnicker, for that excellent talk. The first is a little more general, which is just like, as we find coronary CT trickling into our practice more and more, I was kind of wondering, how do you counsel on the incidental bridge that you come across and the associated risk with that? And then the specific question was about the Stanford classification schema. Once you hit grade 3, does the depth of the bridge matter at all, or purely the fact that it's encased beyond that, was it 0.7 or 1 centimeter cutoff?
Okay, let me see if I remember your first question. What do you do about an incidental finding? Well, if I do a CT and I get an MMI of anything less than 31 and the patient has no symptoms, then I would just leave it at that. They may develop endothelial dysfunction, further on in life, and then you can just be honest with them and say, we have found a bridge, but it looks like it is a very mild bridge and likely not going to cause you any problem. But in the future, if you do develop chest pain, come back and see me. What was the second question? You said something.
Sorry, it was once you hit grade 3, does the depth of the bridge matter, or is it?
Well, if you have designated grade 3, then we know that muscle band is at least 0.7 millimeters, and whether it's 0.7 or 1.7 does only matter if you take the patient to surgery, because if it is that deep, 1.7 say, it's very likely to go into the RV cavity. And you want to do that unroofing, if you're going to go that way, on pump and the sternotomy, and the surgeon should be warned that you are likely to go into the RV, and then you have to, suture that up. But for sort of hemodynamic standpoint, whether it's 0.7 millimeter depth or 1.7, as long as your myocardial mass index is elevated, it's likely to be a hemodynamically important bridge.
Got it. Thank you.
Awesome. Okay, we have a few minutes left for a few more questions. Next one is from Zanyar. Zanyar's still on. Do you want to ask your question? Okay, maybe he can't talk. So his question was, does intracoronary nitro affect the bridge phenotype when imaged in the cath lab?
Very good question. Yes. If you give intracoronary nitroglycerin, what happens to coronary flow? Well, you get vasodilatation and coronary flow increases. Now, the bridge is confined in this tunnel and cannot dilate. So you're trying to now force more blood flow through the tunneled segment, and it will actually look worse. You'll see more of a milking effect because the segment above and below bridge are going to dilate, and the segment cannot dilate. So yes, in the cath lab, if you have pure bridge mechanics, then the bridge will look worse when you give nitro intracoronary. Now, if you have less severe of a bridge and you have a lot of endothelial dysfunction like spasm, it may actually look better because endothelial dysfunction loves nitro, okay? So if you have spasm, if you have pure spasm and give nitro, it will just widen up. The problem is when you have the mix, and that's why, patients often they read online, right? So they say, oh, nitroglycerin is contraindicated in bridge, right? Well, if you only have a hemodynamic problem because of bridge alone, yes, you can get more symptoms, you can feel worse with nitro. If you have a combination of bridge and endothelial dysfunction, it's a plus minus. If you have pure endothelial dysfunction and no bridge or insignificant bridge, you're going to feel better. So it's really a spectrum.
Thank you so much. Yes, my mic was not working. Thank you.
Awesome. Okay, last question comes from Daniel. If Daniel's still on, you want to ask this question? Last but not least. Okay, maybe Daniel can't ask, but the question is, what's the physiologic explanation of the septal buckling on stress echo?
Okay, we have looked at that, not in depth enough, but the septal buckling, if you look at strain imaging in that segment, we have found that you have post-systolic shortening. And post-systolic shortening is a strain pattern that has a double peak. And that has been associated with ischemia. If there's an animal study where they did balloon angioplasty on, I think it was the circumflex artery, and they saw post-systolic shortening for 24 hours following the balloon blowing up the artery for 30 minutes. So you see that same strain pattern in the buckling segment, post-systolic shortening. So although I haven't really proven that in sort of a series of patients, that it's very suggestive that it is the reflection of ischemia. And sometimes you see the bridge pattern already at rest. And then you wonder, is this the residual after an ischemic episode in the prior 24 hours. It always looks worse with stress, but in some patients, you see a mild buckling at rest. And if you do strain on that segment, you'll see postsystolic shortening.
Fantastic. Okay, we're right at 7 o'clock or a little bit past, so we'll end here. But thank you so much, Dr. Schnitger. This was fantastic. And for all of you, thank you for asking your wonderful questions. The recording for this session will be posted on the California ACC Fellow in Training website. I put the link in the chat. It should be up by the end of next week, so check in about a week. Okay, thank you all for coming. Thank you, Dr. Schnitger. This was incredible.
Thank you.
Thank you, Dr.
you.
Schnitger. Thank you,
Fascinating.
Natalie.
Thank you so much.
Thank you.
Thank you.
Bye, everyone.
Bye.
Bye.
Take care, everybody. Have a good night.